Alright, today I'm going to be demonstrating how to do a knee x-ray. It's going to be 5 views. We're going to do an AP, medial oblique, a lateral, an axial, intercondylar, fossa, and a tangential patella. I'm going to start by setting up my console. I'm going to set it to table bucky. I'm going to use a KVP of anywhere between 65 and 75. I'm going to go with 70. And a mass, the range is usually around 8 to 12. We're going to go with 8. I'm going to use a 10 by 12 cassette. I'm going to place it in my table bucky lengthwise. Portrait. And make sure my tube is lined up with my bucky. I'm going to detent my tube to the table. I'm using SID of 40 inches. I'm going to keep this up for my patient, bring them in, and I'm ready to get my patient. Alright, I've had my patient change into a gown. I believe they're ready, so I'm going to go ahead and bring them in. Victor, would you come on in? My name's Cameron. I'm from the radiology department. We're doing a few x-rays of your knee today. Can you confirm your last name and date of birth?
Zaragoza 1358.
Okay. Before we start, is there any possibility of pregnancy?
No way.
Alright. So what brings you in today? What happened?
I was running from the cops and I found my knee.
Okay. And it's your left knee, I see?
Yes.
Alright. I'm going to go ahead and have you lay on the table. Go ahead and place the shield on you. I'm going to raise up my table. Down 40 SID. Alright. Make sure my tube is lined up with my cassette still, which it is. For the AP, central ray is going to enter ½ inch below the apex of the patella. Place my marker, left marker, lateral to the extremity. I'm going to keep a perpendicular angle because he's of average size. He's between 19 centimeters and 24 centimeters. If he was more than 24, it would be a cephalad angle, and if he was less than 19, it would be cotted. But we're going to stick with perpendicular. Make sure his foot is straight, foot is arched up, just like that. Alright, Victor, hold, stay still. Go ahead and take my exposure. Click. Alright. Go ahead and run my cassette. Come in with another one, same 10 by 12. Ready to do the medial oblique. Go ahead and rotate his whole leg in medially, about 45 degrees, just like that. Again, central ray enters ½ an inch below the patellar apex. Keep my same marker, lateral. And again, central ray, it's perpendicular. Density is about the same, so we're going to stick with the same technique, about 70 at 8. Alright, Victor, stay still. Click. Alright, now we're ready to do the lateral. Go ahead and take out my cassette. I'm going to go and scan it. Bring in another 10 by 12. This time we're going to do the lateral view. So I'm going to have the patient roll onto his left side since it's his left knee that's bothering him. Bring the unaffected leg over the front. Go ahead and shield him again. This time we're going to angle the tube about 5 to 7 degrees cephalic. Just the bucky. Central ray is going to enter about 1 inch distal to the medial epicondyle of the femur. Let's begin. Place the left marker. Make sure it's in the field of light, not obscuring any anatomy. And we're ready to take the exposure. Alright, Victor, hold still. Click. Alright, I'm going to go ahead and run this cassette. Alright, before I go any farther, I just want to mention that on that last image, on the lateral, you would have your patient's knee flexed about 20 to 30 degrees. And the technique, I left it the same, but since if the patient's knee was the patient's body part was dense, thick, you would want to bump up the technique a little bit, but I left it the same. Alright, now we're going to do the Baclair. We're going to use an 8x10. I'm going to have the patient roll back onto his back, supine. Place the shield back over him. And we're going to put a support under his left leg. We're going to have his leg arched. We're going to create an angle of about 60 degrees between his femur and his lower leg. A bit more. Place the cassette under the leg. Just like that. And for this one, you want your central ray to be perpendicular to the lower leg. And you're ensuring at 1/2 inch distal to the apex of the patella still. You want to be at 40 inches. Place my marker. And I'm ready to take my exposure. Alright, Victor, hold still. Click. On that one, I used a technique, because we went tabletop, I went down from 70 at 8 down to about 65 at anywhere between 4 and 6. Alright, now I'm ready to do my tangential patella. It's going to be a set of gas method. I'm going to use an 8x10 cassette again. I'm going to take out the support. I'm going to have my patient flex his leg, his affected leg, as much as he can. Just like that. And have him hold the cassette against his femur. We want the cassette to be perpendicular with the patella. Central ray is typically 15 to 20 degrees, but basically you want it perpendicular to the joint space between the patella and the femur. Again, about a 40-inch SID, right about there. I want to see a little bit of light above and on the sides. Place my left marker. Right there. Okay. And on the technique, I would stick at about 65 kVp, drop the mass down to about 1 to 2. Alright, hold it right there. Actually, I would move the shielding a little bit here. Just like that. Alright. Alright, hold it there. Alright, click. Alright, now I'm going to read the image, see how they came out. Okay, now that I've ran my films, I'm ready to critique them to determine whether or not they meet the evaluation criteria to be considered a proper diagnostic image. First here we have the AP knee. First we want to see an open femoral tibial joint space, right here. If the patient's condition permits, the knee should appear fully extended. The patella should be completely superimposed over the femur. There should be no rotation of the femur. The condyles should be symmetrical, and the intercondylar eminence should be centered. We should see slight superimposition of the fibular head behind the lateral condyle of the tibia. Alright, next here we have the AP oblique knee with medial rotation. First of all, the tibia and the fibula should be separated at their proximal articulation. We should be able to see the lateral condyles of both the femur as well as the tibia, here and here, and an open knee joint with both tibial plateaus. Also, we should be able to see the outline of the patella projected over the medial condyle of the femur. Okay, here we have the lateral knee. Here we should see complete superimposition of the femoral condyles, here, and an open space between the femur and the tibia, here, as well as between the femur and the patella, as we can see here. Alright, next we have the AP axial intercondylar fossa, the Beclaire method. On this image we should see an open intercondylar fossa, and the eminence should be easily visualized. There should be no superimposition of the apex of the patella and the fossa, and there should be slight overlap of the tibia and the fibula, which will show that there is no rotation. And lastly, we have the tangential patella with the Satagast method. Here we should see the patella in full profile, as well as an open patellofemoral articulation. And also we should see the surfaces of the femoral condyles.